Thank you very much for inviting me to speak. I'll give you a few moments to put on your headphones, those who wish to. Thank you for inviting me back to Da Nang to present on this. This session is about mycobacteria. We just heard a talk on treatment of non-tuberculous mycobacterial lung disease, and after me, you're going to hear a talk about from Dr. Hashimoto about diagnosis of and laboratory diagnosis of non-tuberculous mycobacteria. But between those two talks, I'm going to talk to you about another mycobacteria, which is called Mycobacterium tuberculosis, which I think you're very familiar with. And I was asked to give an update on diagnosis and treatment of TB. So in this talk, I'll talk first of all about where we stand now with tests for tuberculosis. There are a number of different tests that are available, how we put these together into diagnostic approaches, and then I'll talk a little bit about new regimens for treatment of both drug-susceptible and drug-resistant tuberculosis later. By the way, I'm happy to make my slides available, so probably no need. I'm not sure how they become available, but they are available to you. So this slide describes tests which we might use in the diagnosis of tuberculosis. And you might find it unusual that I've included as the first in that list symptoms. Symptoms are in some way a diagnostic test for tuberculosis, along with X-rays and sputum tests. And so I think it's easiest to think about symptoms in the same context that we think about other tests. But I think the main thing to know about symptoms in relation to tuberculosis is that they're not a good test for TB. They're a very poor guide to whether a patient has TB or not. For example, in our study in KHOA in Vietnam in 2014, we found 169 people, in screening the whole population of 60 villages, 60 subcommunes, we found 169 people who had TB on bacteriological confirmation, but only less than half of those people had reported symptoms. So what that means is, if you think about symptoms as a test for TB, they have a sensitivity of, in this case, 44%, a very low sensitivity test. So the absence of symptoms is not a good way of ruling out the diagnosis of TB. More people with TB do not have symptoms than have symptoms. On the other hand, symptoms are what bring patients to see the doctor. People don't go to see the doctor or a health post or anybody else unless they have something wrong. They don't go and say, "I'm well, please test me." They go and say, "I'm sick. Okay, I've got cough, I've got breathlessness, I've got fever, I've got weight loss." So symptoms are what bring patients to the doctor, and they need to be diagnosed. The point is that most people who have symptoms of cough, even in a country like Vietnam, where TB is quite common, most people who go to see the doctor with cough or shortness of breath or fever or weight loss do not have TB. They do have a problem, but that problem is not TB. It may be TB, but most people it is not TB. So they don't want you, if you go and see the doctor and you've got a cough and shortness of breath and you're losing weight, and the doctor says, I've got good news, you don't have TB, now go away. Is that what the patient wants you to do? They don't. They don't want you, they want you to tell you, they want you to tell them why they have cough, shortness of breath and weight loss and what you can do about it. They don't just want you to tell them that you don't have TB. So we look at this through the wrong viewpoint. We need to look at this from the viewpoint of the patient who has symptoms and who wants a diagnosis. So symptoms are important for initiating investigation. And that investigation should include investigation for TB. But if the person does not have TB, then they should be investigated for other causes like pneumonia, like cancer, like bronchiectasis, like all of the other things that cause, like non-tuberculous mycobacteria, like all of the other things that cause those symptoms. I also think we need to stop using the term TB suspects, okay, to define people who have symptoms. This has become very common, that people who have symptoms are referred to as TB suspects. This is a very bad term. It's a very bad term for several reasons. One is because it stigmatizes patients. The word suspect is what we use for criminals, people who are suspected of committing a murder, people who are suspected of robbing. And being suspected of having TB is not how we should stigmatize people. The other reason that is because it's inaccurate. Most people, as I said earlier, most people who have cough, shortness of breath, or weight loss do not have TB. They have some other problem. Okay? So we need to think of them as patients who have a problem and need a diagnosis, not as suspects for anything. So that's symptoms. So as you see, I'm saying that symptoms are useful for bringing people to attention that they need investigation, but not useful for the diagnosis of TB. Radiology has had a role in the diagnosis of TB for about 110 years. We've had radiology, chest X-ray, since the first decade of the 20th century. So there's a very long history of radiology for diagnosis of TB and of other lung disease. And it is very useful, but its main use in relation to tuberculosis is in triage. So a normal chest X-ray, a chest X-ray which shows no abnormalities, makes the diagnosis of pulmonary tuberculosis quite unlikely. Not impossible, but quite unlikely. So if you're thinking of TB and the X-ray is normal, it's probably better to think of another diagnosis as the cause for the patient's symptoms. You may still want to test for TB, but you would probably need to have a very good reason to do a further test for TB in a person who has a normal chest X-ray. On the other hand, a positive chest X-ray, which looks abnormal for TB, may be useful, but it still needs to be tested, confirmed by bacteriological testing. So in fact, most people who have symptoms and an abnormal chest X-ray do not have active TB as the cause for their symptoms. That's important to recognize, okay? Most people with symptoms and an abnormal chest X-ray do not have TB as the cause for their symptoms. The abnormal X-ray is due to some other cause, or it's due to TB that they had many years ago and healed itself, and they have another cause for their breathlessness. So you should not assume that the presence of an abnormal chest X-ray means that the person definitely has TB as the cause for their symptoms. You need to confirm or refute that diagnosis with a microbiological test. Having said that, I think X-ray still does have a significant role in investigation of patients who present with respiratory symptoms, with cough, shortness of breath, fever, or weight loss. It's an important investigation, and some technologies that have evolved in the last 5 to 10 years make it much, much more accessible than it used to be. Okay? So it used to be that you could only really get a chest X-ray in a major centre, and it would take quite some time to get the X-ray, and you'd have to wait for a radiologist to report it, and it was not a very accessible test. Two important developments now make radiology much more accessible, and I think in the future will be accessible right down to the level of commune health posts, in Vietnam. And these are ultra-portable radiology, which is battery operated, very portable, can be very low radiation and therefore safe. They use a very highly sensitive detector, and it could be operated by somebody with very little training of about 6 weeks. It does not require a highly skilled radiographer to operate. So it becomes suddenly much easier to deploy to peripheral levels of the healthcare system, and I think that's what the future holds. The other part is the AI reading, or machine learning reading of images. So this has advanced very rapidly and is continuing to advance rapidly, and now actually AI reading of X-ray images is more accurate for the diagnosis of TB and of some other lung conditions than is a radiologist, a specialist human radiologist. So, and this makes it, again, much more accessible to people operating in the most peripheral levels of the healthcare system. So a doctor working in a health post, or even a non-doctor healthcare worker working in a health post, can take the image and get it interpreted and get the information that's available from a chest X-ray. It's a big step forward. This is an example of us. We've been doing this in KHOA now for some years. I love this image because if you look carefully at this woman, you see that the diagnosis of her problem is made not by the image, but by her posture standing in front of the X-ray machine. How is she standing? Is she standing straight? No, she is not standing straight. She came up to the X-ray machine like this. She has Pott's disease of the spine. So it's not the image, it's the actual. So that's why I particularly like this picture. So I want to move on to molecular tests, where there have been very major advances. And molecular tests are the future of the diagnosis of TB. And they're mainly referred to generically as nucleic acid amplification tests. Sometimes they're PCR, sometimes they're other nucleic acid amplification tests. And they, the readout from the nucleic acid amplification test is, there are usually two readouts that we get, two reports that we get when we perform a nucleic acid amplification test on a specimen, usually a sputum. We get, is TB present or not? Is TB detected? And secondly, we get information about drug resistance, particularly about rifampicin resistance, but we can also get information about other drug resistance from the molecular test. And this is performed directly on a sputum specimen. So we don't need to do any pre-treatment, and we can get a readout within about 2 hours. This, of course, is different from what we used to have to do, which would take days to weeks to get a readout on the diagnosis of TB. Now you can get a readout in 2 hours. It's fully or partially automated. So again, we don't need highly trained, sophisticated laboratories or staff. In fact, we don't even need we don't need highly specialized containment facilities, infection control facilities to perform this test. It's highly specific. So if you get a positive test, it's almost certain that the patient has Mycobacterium tuberculosis in their sputum. The main limitation on the specificity is in the patients who've had recent treatment for TB. So the recent treatment of TB may have killed the mycobacteria and they're effectively cured, but there is still mycobacterial DNA present and you can still get a positive test. So false positives almost always occur in people who've had completed recent treatment for TB. The sensitivity, particularly of the newest forms of these tests, is very high and approaches the sensitivity of mycobacterial culture. So it's a highly specific test and a highly sensitive test. And that's the best that we can get. A highly sensitive and a highly specific test is what we want for diagnosis. There are some emerging developments with these molecular tests which you should know about and which will be in front of you in the near future. One is that although the currently approved tests are Expert and TrueNat from Molbio in India, Expert from Kefid, there are competitors rapidly emerging onto the market which will be much cheaper than both of those tests. So we're looking at a test which will be $1 to $2 to $2.50 per sample, much cheaper than the current tests, US dollars per sample. And they're mainly coming from China and some coming from India. Okay, they're not mainly coming from the United States or Europe, they're mainly coming from China and India. There are also alternative platforms being developed which have different uses. And by platforms, I mean how you actually do the testing. There are increasingly now platforms that allow point-of-care testing. That means a test you can have in the commune health post, in the clinic, in the place where the patient is coming to be tested. And you can test them at that point. That's point-of-care test. And that's useful for the clinical setting, where you have patients that have, as I said earlier, people presenting with cough, shortness of breath, weight loss or fever, and you want to rule out or diagnose TB in those people. These point-of-care tests where you can do the test at the time when the patient is there is very useful. The other platform that is emerging is very high throughput platforms developed by the big companies, Becton Dickinson, Roche, Abbott. They've all got high throughput platforms. And these will be used, I think, in the future, not for clinical purposes, but for mass screening, for public health purposes. We'll be able to collect sputum specimens from many people and subject them to mass screening using these high throughput platforms. The other development that is emerging is the use of new specimens. Traditionally, this has been done on sputum. That's what we use for sputum microscopy, sputum culture, and we use sputum for testing on with the nucleic acid amplification tests. But increasingly, we've got the availability to test other specimens, including those that are shown here. And the one I want to particularly focus on is this tongue or mouth swab. Some people can't produce sputum, but they still have mycobacterial DNA in their mouth. And you can collect, if they don't produce sputum, you can test secretions in the mouth using the same platform. So this is a future way in which we'll be able to diagnose TB in people who can't produce sputum. The last one on diagnosis is old microbiology. Okay, so this is microbiology that's been available since the 19th century, 130, 140 years. It's had a very long run. It's time for it to retire, like it's time for me to retire. I'm ready to retire, but we also need to retire old technology, okay? So sputum smear microscopy really has no role in the management of TB, okay? It is not useful for the diagnosis of TB, has very low sensitivity, has quite low specificity. It has no role in the diagnosis of TB. Officially, in the WHO guidelines, people still talk about monitoring sputum smear microscopy for treatment outcomes. That is still in the guidelines. I think it will come out of the guidelines soon because it's not really very useful, but it is still there in the guidelines. I think the role in the follow-up of diagnosed patients needs to be reviewed. I think there is still a role for mycobacterial culture, but much less than there was before. In Vietnam, most patients diagnosed with TB have never got mycobacterial culture. The vast majority of TB patients never get a culture. And there has been investment in building up culture capacity, but I think now is the time to move away from that and to invest instead on building up the nucleic acid amplification tests. I think it has some role in the investigation and management of patients with treatment failure or relapse. There are rare cases of TB that require special investigation, and it has a role at a public health level in surveillance and monitoring. Drug susceptibility testing, that's phenotypic drug susceptibility testing, the traditional way of drug susceptibility testing, still has some role, but it's rapidly being replaced by the molecular tests. So how do we put all these together? How do we put all these together into a diagnostic approach? Well, I think that actually nucleic acid amplification tests, in the vast majority of cases, should be the sole test used for the diagnosis and for identifying drug resistance. The sole test. Chest X-ray may be used as a triage test, and importantly, as I said earlier, for that to help in diagnosing other causes of respiratory symptoms. So I'm going to move on quickly because I don't have much time left, 1:40, about treatment. I don't have so much to say about treatment. Most of I think the innovation has been in diagnostics. But in treatment, we need to, I think, keep a strong focus on what our goals are for treatment. Whatever we do for patients who we know have TB, we need to make sure that we can give them a rapid and sustained microbiological cure. That has always been the goal, and it remains the goal. But sometimes we forget about it. It's very important we don't forget that that's what we're trying to achieve. And the reason we're trying to achieve that is to prevent transmission to others, and also to prevent progression and to allow regression of the lung disease or the disease in the person who has the problem. So both problems, prevent transmission and cure the person of their disease. We also, though, want to achieve this with minimum toxicity. And that's always, we have these multi-drug regimens, often drugs that can be quite toxic. We want to avoid severe sequelae, severe consequences, both of the disease and of the treatment. We want to avoid treatment interruptions, because the main reason for treatment interruptions is drug toxicity. And we want to avoid, as much as possible, interference in the patient's lifestyle so that they can get on with work, with their family role, with doing whatever they need to do. And finally, we're looking to have shorter regimens because that's less costly for the health system, and also it's less costly for the patient. And the final point is we want to make sure that when we treat patients, we don't cause the emergence of acquired drug resistance. This is the fourth goal. So 4 important goals of treatment: rapid and sustained microbiological cure, minimum toxicity, shorter duration, and very low risk of acquired drug resistance. The major steps forward in treatment actually are diagnostic tests. The ability now, until fairly recently in Vietnam and in many other countries, the only way you had of finding if a person had drug resistance was to give them treatment for drug-susceptible TB and see if they failed. So you would treat patients with the standard treatment for drug-susceptible disease, and after 6 months you'd realise that they had failed treatment, and you'd diagnose drug-resistant disease and put them onto another regimen. By that time, the patient had become much sicker and had probably infected a whole lot of other people. That was a disaster for the patients and a disaster for public health. We now have the capacity and should ensure that every patient who has drug-resistant TB is diagnosed with drug resistance before they start treatment. And we can do that using the nucleic acid amplification tests, EXPERT or TrueNat, or any of the new tests. So we need to make sure that we have done that test and we can diagnose drug resistance at the time of treatment, initial treatment initiation. That's the critical and the most important advance in treatment of TB. The other very important advance is the development of new regimens for treatment of rifampicin-resistant TB. And these new regimens are all oral, no need for injections, which are toxic and very unpleasant for patients, no need for patients to attend hospital, no need for patients to be admitted to hospital, and they can be given for in 6 months. They can be completed in 6 months, the same duration as drug-susceptible disease. So the BPALM, that's bedaquiline, protonamide, linezolid, and moxifloxacin regimen, is generally well tolerated and highly effective. And it can be and it's effective against not just rifampicin-resistant TB, but multi-drug resistant TB, and also, in fact, extensively drug-resistant TB. TB that is resistant to injectables and even fluoroquinolones. There are some clouds on the horizon. There are some problems ahead. One is that in some countries, and I'm not sure about Vietnam, but certainly in South Africa and in India, they're starting to see significant incidents of bedaquiline resistance. And if you have bedaquiline resistance, that's going to be a major problem for the BPALM regimen. And the other significant problem is that, at least in some settings, there is quite a bit of toxicity from linezolid, and that also is a problem. And there are investigations going on to try and improve this. Just briefly, other steps for child-friendly formulations, very important in pediatric TB. Shorter regimens, particularly for children with non-severe disease. We now have 4-month regimen that is widely used in children with non-severe disease. There's also a shorter regimen for adults, but that is not as widely used at the moment. So in conclusion, I think the rapid advances in diagnostic technology and in treatment regimens, especially for drug-resistant TB, have been the major development that have improved our capacity to manage TB. Further important advances are in the pipeline and will be coming to you soon. The major problem that we have is the slow uptake of these advances. And this is not mainly due to cost. It's mainly due to regulation and also to slow change in clinical guidelines. It's not mainly due to cost. It's mainly due to these other factors. And I think we need to push to make sure that these new innovations are widely available in Vietnam and used by people for managing TB, and we will have much better outcomes for patients with respiratory disease. So I'll finish there, and thank you again very much for inviting me to speak.